Welcome back to episode 65 of the Sports Medicine Project. I'm Blake. I'm here with my co-host Kelly Kortic. 29 single leg calf raise PB. Kelly, how you going?
I'm good. 29 on the right, 27 on the left. Got a bit of work to do on the
29,
left.
27. But don't you only have to be 90% to return to sport? Or it's rough, or that's ACLs. 90% is the rough estimate of what you should be in symmetry?
I think so. I often say that for a lot of things when we're doing testing, that if you can get within 90%, that's where we're more okay with the result. If it's outside of those ranges, then may as well work on it, I think.
Yeah. I think, I find patients want to try and be 100%, and most of the time I'm explaining that, and I use the analogy, I don't know if it's right, I usually say something along the lines of humans aren't built like cars. We're always going to have some asymmetry, which is completely normal, but we're more focused on the capacity of the tissue and how it relates to what you want to get back to.
Particularly with sports where one side is going to be more dominant than the other side, like baseball or cricket or something like that, where your dominant arm is obviously going to be stronger than the non-dominant arm.
Yeah, that's true. Now, we've got a whole bunch of new followers, and I feel as though we're saying this every week, which is awesome. So we're nearly on the 2K with the Instagram, which is great. And if you're listening to this and do follow us on the Instagram, you probably would have come across from there. So I thought we would go through a small introduction of what we do and who we are. You want to go first?
You go first.
No, you go first. You're the leader.
No, you go, because I've already thought of what I'm going to say.
All right, then. All right, well, I'll go. So Kelly's the actual host. I'm the co-host, the guy in the background. So my name is Blake. I predominantly work at Achieve Podiatry here in Newcastle. So I'm a podiatrist, and I work predominantly in the musculoskeletal space. I work in a clinic with a bunch of sports doctors and sports physicians. So we deal a lot with the musculoskeletal side of podiatry, which I thoroughly enjoy. And then I work also at the Newcastle University. I teach in basically orthotics and podiatry skills, and also lecture in biomechanics. Now, I put this in here, which sounds a little bit, I don't know what it sounds like, but I wanted the listeners to at least know, because we talk a lot about rehab and a lot about running. Kelly and I both run and lift, so we each probably run about 70 Ks a week and lift, a couple of times, 2 to 4 times a week. I co-run the Future Health Network with Dave Renfrew and Justin Smith, which is an education platform for clinicians. Do some research around pain, running and footwear, and I've had a paper published in the Journal of Sports Science, which is awesome. What about yourself, Kelly?
So my name's Kelly. I'm a physiotherapist at Newcastle Performance Physiotherapy. I particularly like lower limb rehab in the physio space, particularly working with runners and female athletes. That's my main cup of tea. And I have a better work-life balance than you, based off the length of my bio compared to yours.
Well, that doesn't mean anything at all. That don't mean anything.
The end.
No.
That's me.
What about your running? So you run... I
like running.
66 Ks this week.
Mm-hmm.
Yeah, and you also gym as well. Yeah.
I run, and
you love life.
I love life. I like coffee in the morning, and I like to have some downtime on the weekend.
Yeah, nice. We don't want this to turn into a lifestyle podcast. We better keep it clinical.
Keep it clinical.
Yeah, so we are this episode focusing on a couple of different topics. We've got about 7 or 8, and we're going to do this in 2 parts. But once a month, we're going to have just Kelly and I discuss a couple of cases, a couple of the things that we go through as younger clinicians as well. So Kelly and I, you've been out for 4 years?
This is my 5th year.
Fifth year?
Mm-hmm.
Right. Are you sure?
Mm.
Yeah, okay. And I've been out for 3.5 years. So we're definitely in the early stages of our career, and we feel as though that gives us a somewhat of a unique perspective compared to people that have been out for 20 or 30 years or even 10 years, compared to also people that have been out for 6 months to a year.
And on that note, the reason we started this podcast for the new listeners is to open up discussion around some of the topics that we come across in a week, in a day, in the physio-podiatry health professional space. So we wanted to have a platform where we can ask experts about their research they've done, their clinical experiences in working with particular patients and what they found across the years. We don't want to pretend to be experts, because I don't think that we are.
No,
We're
definitely not.
passionate in the area, and we love talking about physio, and we love having these discussions. And
more than physio, we just like talking about the body.
We love talking about the body. We love talking about
typical
rehab.
physios think they know it all.
But we also don't want to pretend to be the experts that we're not, and I think that that's important to say, because sometimes we will have discussions and we'll throw our opinions in there because that's our podcast and that's what we are going to be talking about. But always, worth questioning the things that we say. If you're not 100% sure, going to the source is always recommended. And I think that goes for anything that you hear anywhere, regardless of who says it. Go to the source
No, not for me. Don't go to the sources of what I say, because I just make things up.
But say that.
We don't make things up.
No one's going to believe anything we say.
Yeah, I know there are people that message us through the Instagram for the papers, and I've got them all on my computer, so it doesn't take me very long to send them through or to send a link through. We
do our very best to keep everything research based, and it's everything we say is to the very best of our knowledge at that point in time. But that might change because everything is constantly changing.
To change. Yeah, that science. If it doesn't change, and if someone's been peddling or talking about the same idea for 20 years, you know that they're wrong, because things have changed and always will change. That is definitely science. Or not change. Not change completely, but
maybe
it definitely does deviate somewhat, for sure. Cool. You want to get us started? Do you want to run through the health news?
No, because I don't know what any of this is you're talking about.
Yep, sweet. Well, I'll start us through that. So I wanted to get this segment out of the way first, because it's the one that usually takes us the longest, but we'll whip through it. So I wanted to talk about 3 cool studies that I read this week that I thought were pretty interesting. Now, the first one...
You're going to start the podcast with the boring part of the podcast.
This is not boring. What if people love to be like, I just don't have time for the research. I wish I could get a quick snippet of some cool study that came out.
Go.
Also, that's what we've got to add. So Kelly and I, you may detect a little bit of banter, a little bit of staleness. Like, these two are really hating on each other. But Kelly and I are partners.
Yeah, and we don't hate each other. It's just banter.
It is banter. And for people that know us... it's funny, like even our last week's episode, probably the last couple of minutes before Peter Maliaris got on to part 2, we weren't talking anything clinical, we were talking about something else, and we had a lot of people say that was probably the best segment. It's the funniest part.
Really?
So it could turn into a lifestyle podcast.
Yeah, lifestyle health professionals.
Yeah. So... Number 1, now this went out in this week's research review, and you haven't signed up for that, please head over to our Instagram. In the bio, there'll be a sign up, and you just put your email and name in there, and then you can become a better clinician for free. So don't know why you wouldn't want to do it. But this week was the adductor strengthening program can reduce the incidence of adductor injuries in season. So they had 2 groups. I think they had 36 teams. It was over 1,000 people, which is awesome. Sorry, over 200 people, which is awesome. They had a group of teams not get the program and a bunch of teams get the program. 3 different levels. It was the Copenhagen, where you hold up the leg and they pull their leg out, and then there was some simplified versions of that. But did that for a period of time and found that overall doing it reduced the incidence of adductor injuries in season, which was really cool. And it's so easy to add in, and there's no harm in doing it. Of course, there's lots of variables, but as simple as holding someone's leg up and then bringing their leg up to that for 3 sets of 10. They did it once a week in season and twice a week in the pre-season, reduce the incidence of adductor injuries. Do you think that's pretty cool?
I think I have read something similar to this before. My critique on this study is that it was, so across the 2 groups, both groups were doing something, and then the intervention group was doing their usual plus this on top of it. And I think that makes it a bit of an unfair advantage, I guess, towards that group. Like, they need to have 2 groups, and then they have the adductor program, and then the other group has something else in there as well, like a lunge or I don't know, whatever.
Yeah.
Because if they're doing more, then they're obviously going to get stronger than the group that's not doing as much. Does that make sense?
Yeah. Will they get specifically stronger in the sense of reducing their risk of adductor injuries? Would you expect that? Or just stronger overall?
I know, well, they're doing more, so you'd expect that they're going to get more benefit.
Yeah, that's true. And no study is ever perfect. I just thought that was pretty cool. I can't remember the exact percentage. I'd have to look that up, but it's in the email. But it was at least statistically significant, which was pretty good. Second one, and I think we've all heard this before, but walking, running, any kind of physical activity not found to be related to the increase in the structural progression of knee OA, which I thought that was pretty cool. And people, not that if patients are asking that we say, no, the research says this, but it's good for us to know when we're basing that and telling people that if you do more and you be more physically active, to a degree, you're not going to make your knee structurally worse. I think that's pretty good. Now we've got something to base that on.
Haven't you seen? That's been out for a while.
No, this is a new one.
Have you seen that though? There's an older study and it shows running across 3 different groups. So there's like elite runners, recreational runners, and then sedentary people. And it was the sedentary group sedentary and elite runners will
It's the incidence of knee OA. I know the study you're talking about. I'm talking about the structural progression.
What's the difference?
Incidence is getting knee OA. Structural progression is the structural change. And there's a difference between the two.
I still feel like that's not new. Don't we know that?
Yeah. I mean, you must have known. I mean, you read research all the time. But for me, no, I'm joking. No, but I didn't.
Yeah, no, I love it. It's a great study. Thank you for reminding me of it.
Yeah, sweet. I'll make sure to run these by you next time I put these through. I just thought that was cool because when I say, and I mustn't have seen that I've studied, but I do know the one that you're talking about is running specific.
So you're talking about people that already have OA can start or continue walking and running and something make it worse.
Without making it structurally worse.
So almost like pain doesn't equal damage.
Yeah, but it's just another one we can add to the repertoire. For me, I just thought that study was cool for my... I don't know if any of the listeners will think it's cool. I know you absolutely hate it, which is fine.
I like it. Yeah, sorry, carry on.
That's right. So the other study which I talked about on the Instagram this week was MRI alone not being able to predict a painful knee in the context of knee osteoarthritis. So I thought this was awesome. They had 3 groups. I'm going to make sure I don't butcher it, but they had a group with no pain, a group with pain in one knee, and then a group with pain in both knees, and they MRI'd them all, and they had a look to see if they could predict who had a painful knee based purely off structure, and they couldn't, which is really cool. So they found that people with pain in one knee, if they were to MRI both knees, they wouldn't be able to predict which knee was sore. However, when they did then correlate and bring the pain across, they found that in the painful knee, it was structurally, in quotation marks, worse or more indicative of OA. So they concluded that, yes, while MRI can't always predict which knee will be painful, structure definitely has a strong association with knee osteoarthritis. So they think it may be implicated.
Structure has a strong association with knee osteoarthritis?
Yeah, the structure of the knee, just purely based off that study. So
I don't think that makes sense. Knee osteoarthritis...
Sorry, the clinical signs on the imaging signs, radiographical signs on imaging have a strong association with pain. Mm-hmm. So I've heard this many times, and I was definitely one that peddled this years ago, where I would talk about structure not really mattering, and I guess I would talk about it in the context of what they can do. Maybe it doesn't, or I would say it doesn't matter, and now I'm a little bit more refrained in saying that there probably is something there that does matter, and it may be implicated in the etiology, and I wouldn't explain that to a patient, but it definitely has some importance.
The way that I tend to navigate that is when patients come in with MRIs of their lower back or their knees or something, I will often say, there's definitely reason in your images as to why your back or your knee or your area is feeling the way that it is. I don't think that that's the only reason though that you're feeling your symptoms. I think that that's a factor and probably a reasonable component as to why your knee hurts in the way that it does.
Yeah.
These things are also influencing your symptoms at the moment as well, and then I'll draw the cup analogy or something like that and give them some other ideas of things that could be involved in what they're experiencing.
Yeah, great. Awesome. Do you want to talk about any of your studies, or do you want to get straight into the next topic?
Next topic.
Great. You want to start it off? You're number 1.
I wanted to talk about the menstrual cycle. I feel like we haven't talked about this in a while.
You've written an essay here.
I just was writing out my thoughts, and I'm not going to just read it, but that's just what I was thinking when I was writing it all down.
Yeah, it's good.
So we haven't spoken about this in a while, and I just wanted to, do a little bit of a touch up on what some of the latest stuff that's been out. So the menstrual cycle has two more distinct phases. So there's the follicular phase, which starts on day 1, when a woman first starts bleeding, and then that's the first half of the phase of the menstrual cycle, and then we go into the luteal phase. So that's the back end of the menstrual cycle, where hormones are on the rise, and that's after ovulation if an egg hasn't been fertilized before they go back into the follicular phase again. Now, I guess over the last few years, there's been a lot of talk about training around the menstrual cycle, and is there a way that you can optimize training around the menstrual cycle? And there was probably a strong-ish thought that your more sort of peak performance is that follicular phase, and you start to sort of taper off performance-wise in the back end of your luteal phase. Yeah.
But it's not a huge taper. It's not a 40% reduction.
No,
is it? It's only a small. If it is, it's only a small reduction.
Well, and that's not even really what the thought was, and this is maybe me being a little bit closed-minded and just being in my bubble of reading the things that I've been seeing. It's more sort of has implied that first phase of your cycle during the follicular phase is when your body is more replicating a male, so you've got a tendency towards speed and lifting heavier and hitting PBs and things like that, whereas in that luteal phase your body's sort of more in favor of the muscular endurance side of things, where you can go for longer and slower but sustain for a greater amount of time. And a lot of women tend to have the more intense symptoms that week before their period. So the very end of the luteal phase is sort of what the strong discussion was around, particularly 12 months ago. And we did a podcast on this previously, and I've probably swung back a little bit from what we were discussing then. So since then, there's been more research that's come out, and some of that has said that no, the hormones of your menstrual cycle don't actually matter that much. It's more to do with your psychological state as to if you perform or if you train better in some phases than other, rather than hormonal variations. And then other research has come out saying that it's inconclusive, and then other research has come out saying nope, follicular phase is when you can lift heavier and perform better, and the luteal phase is when it's a bit more sort of rest and a recovery kind of phase. And so I think, to summarize all of that, I think we still don't know, and I think there's still a lot of research that needs to be done. What I think has been really cool, though, is that there's been more discussion around it, and a lot more women are tracking their symptoms, and they're monitoring their symptoms, and they're actually thinking about how they're feeling across different phases of their cycles. And that conversation has been opened up a lot more, where women are just comfortably talking about it and having more discussions around the community around their menstrual cycle, which I think is a good thing. What has been frustrating me lately is there's been people posting about the phases of the menstrual cycle being sort of noceboed, or women thinking that they're in a negative slump because of the phase that they're in, or maybe using the phases of their menstrual cycle as an excuse for not performing. And that's been just various posts that I've seen on social media that people have put out there. And it frustrates me for a couple of reasons. Number one is that I don't think it's an excuse for women to say that they're not feeling very good during a particular phase of their menstrual cycle. I think if they've been tracking and monitoring their symptoms and they do identify that they don't feel very good during one phase of their cycle, they're allowed to not feel good.
So you said it's not an excuse, or you mean to say it's a valid reason?
I think it's a valid reason that people can not feel good. I don't think it's an excuse that they're copping out of a training because they don't feel good.
Yeah.
And if they're monitoring their symptoms across their menstrual phase, then I don't know that people can say, no, you don't feel bad because of your cycle. I don't think they can make that claim. I think it's good that people are more aware of it and at least asking the question. And yeah, I don't know, that's just something that's been frustrating me. And I agree that there's more research to be done, and we don't have anything like definitive to say that the follicular phase is the way to go and the luteal phase isn't. But I do think that women are allowed to have weeks where they don't feel great, and if that consistently aligns with where they are in their menstrual cycle, then that's okay.
Yeah, I agree. I saw a post from, I think it's Angus Bradley, he's a guy I follow on Instagram. He was saying that trainers, and he coaches and does seminars for mostly PTs, but he puts up some blunt posts and puts up some good posts as well. But he was saying trainers shouldn't worry about trying to program around women's menstrual cycle because there's more things that they can focus on to get right, which I agree somewhat, but I don't know if you can say that because you don't have as good of an understanding as what you could, or is that valid? What do you think? Do you think that people should go out and learn more about it so they can do it, or focus on all the other things and then not really worry about that?
I think that it needs to be discussed with each individual woman around how they feel at particular phases of their cycle, because
that's difficult.
I don't think that there's...
For a male, I'm talking like a young 20 to 30-year-old male, that can be a difficult conversation.
If they're going to do it, then that's how they should do it, though.
Yeah.
Like, if they're not...
I agree.
If they're going to try and do it at all, then it needs to be collaborative with that individual woman, because some women feel horrible during the week that they're on their period. Other women feel amazing. Anyways, that's just a thought that I've had and something that I've been seeing pop up a little bit, so just wanted to discuss it because I don't think we have for a while. Cool. So next topic, you've got athlete's foot lateral fifth fracture.
Yeah.
Talk to me.
Yeah. So I had a lovely lady that had fractured her fifth metatarsal several months ago, and it healed to some degree. It had healed via x-ray, and she was still getting some pain on the outside, so sent to me for kind of seeing why we're still getting that discomfort. But I'll keep this quite short. We went through all things that we do, followed her history and what had happened, and quite an active person, wants to be active, goes to the gym, walks 5-6 kilometers a week, and we got to the part where we have a look at their shoes and talk about that. And she mentioned that she had gone to a footwear place to get fitted with some shoes, got a pair of Brooks Adrenaline GTS, which is basically, you imagine a shoe on the outside and the inside. Their guide rail system are these two almost like wedges that sit and try and hold the foot in somewhat of a neutral position, which was a great shoe. She had a little bit more of a caver's foot type, so definitely putting a little bit more weight through the outside of that foot. But had a look at the shoe, relatively new. I was like, oh, what's that in the shoe? Pulled out, and she'd been given an inner sole, which again is fine. However, in someone with a little bit more of a caver's foot, in an inner sole, that's going to be tipping her more laterally onto the site where she was getting the discomfort. So it was just frustrating that had happened, and I think it was one of the bigger contributors as to why the pain probably wasn't improving. If you're in a great shoe, which is awesome, you're an active person, but you're in something that's tipping and putting force on the outside of the foot, that's obviously going to be contributing to it not getting better and also getting the pain and discomfort. And it just made me think about all the places, and it's not just podiatry and orthotics, there's all different kinds of similar scenarios, but when retailers tiptoe a little bit into the health sphere, not always does it matter, and not always do they get it wrong. And I always hear the argument of, it's fine, we're not doing open heart surgery, it doesn't really matter if I give someone some orthotics, or I'm a PT and I give someone some nutritional advice, it doesn't really matter. But in that case, it really does matter. And I use the example of someone, a type 2 diabetic, is it pretty important that they see a dietitian or someone with more of a qualification to give nutritional advice. Of course it is, compared to, say, a personal trainer or somebody online. And is it important that this person with a second metatarsal stretch fracture doesn't get an orthotic from the Good Feet store? It is really important, because it could very likely make things worse and lead to a cascade of problems in the future. And yeah, it was just...
How did you manage that? Did you tell her that that was bad, or did you try and sugarcoat it a bit?
I just said that it was probably contributing to some of the discomfort, and the good thing is it doesn't seem like things have gotten any worse, and she was still quite active, which was awesome. So great, if this fracture was developing, into something, as it was not too long ago, it's very likely it would feel worse, and it's fine. We can take it out. You've got a good shoe, and just kind of quickly brushed over it and just said, great, this is what we're now going to do, and just made her something with a lateral wedge on the outside, and hopefully things are starting to improve. But yeah, it was...
Were those orthotics that she'd gotten from Athlete's Foot?
Sorry?
Were they orthotics that she had gotten from Athlete's Foot?
Yeah, just a normal off-the-shelf one, which, again, I'm not saying that, and this is the hard part to grasp, is we as health professionals don't own a treatment. We don't own rehab, we don't own orthotics, we don't own footwear prescription. However, in the presence of pain, a medical professional's advice is important. Another example, and I wrote a post on this on LinkedIn, should the online trainer keep telling the 55-year-old woman with a history of bone pathology and osteopenia to keep hopping for this odd back pain that keeps getting worse and is painful at night? Like, there's definitely cases where, for the majority of people, that is fine and you can get coached online, but if in this case, a 55-year-old woman with osteopenia and very likely sounds like maybe a sacral stressy or a femoral stressy, should someone be getting advice?
Lumbar.
Yeah, or lumbar. When is it appropriate for, I guess you could say, the retail space to refer on? And it probably should be sooner rather than later, because the best case scenario is they go and see someone. Oh, great, no, it's just that. Just modify this. I'll communicate with the trainer and you can continue to do that. Or the worst case scenario is they keep doing that and things get a lot worse, and then this person's now got 6 to 12 months of pain and we're trying to get it better. That was just frustrating, and I don't have a right or wrong answer, but it was just something that happened during the week.
The other thing as well, like for example, Athlete's Foot or retailers, we refer people to footwear shops all the time, and if a retailer has identified that someone needs to come and see us, that makes them look so even better than, I think that makes me even more confident to send people to them, because I know that they're able to identify when someone might need a second set of eyes on a painful problem.
Yeah, it's hard, but I'm not blaming Athlete's Foot at all. I mean, it's not Athlete's Foot job to train their people to identify pain and when it's appropriate to send to podiatry. So if anything, it's actually on me for not going over there and educating them. But it was still frustrating that without any input from anyone else, if you see somebody in pain, and I imagine this is a retailer, you just automatically think, yep, you need this, without really consulting and knowing that there's obviously going to be consequences. It seems really logical, and I don't know if I'm biased just because I'm a health professional, and when I see somebody in pain, I have to think about all the other things that it possibly could be and all the treatments and consequences.
And also maybe that patient didn't talk to them about it either.
No, she mentioned it.
Oh, she did.
Yeah. So, yeah, that was just a frustrating one. But anyway, I'm sure it happens all the time, but it's just something to be aware of. And, yeah, if anything, I guess it's on you as a health practitioner or a clinician to educate the people around you, and that'll be on me to go over and have some communication, education with them, hopefully.
That's good.
You put something about iMoveU, something about the happiest career. Can you move your knees away?
No.
You keep going to bloody give me a tibial stress here. You keep bumping into it and knocking it.
Maybe you need to cut your legs off. They're a bit too long.
Hey, don't tall shame me just because I'm a big guy. Don't shame me on this podcast.
We're both sitting the same way.
Yeah.
Did you see that iMoveU post about the happiest careers?
Oh, yeah, I did see that.
Yeah. So iMoveU, which is a Facebook group on Facebook. Yeah. Did a post about the happiest careers, and physical therapy was number one. And I looked at that and I was like, that's so cool. And then I proceeded to read the comments of the post, and it was just so sarcastic, and it made me really sad. And it was just a lot of people being like, lol, who wrote this, blah, 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 blah. And I really like my job, and I like working as a physio, and honestly, I think we are lucky to have the job that we do. I think it's rewarding, I think it's fun, and we get a good work-life balance. Well, I do, not you. Maybe it's not as well paid as some of the other jobs in the world, but money doesn't buy happiness. And yeah, I think I do. I think we're lucky to be working in this profession, and I'm just interested as to why people joke about it and why people don't believe that physio is one of the happiest careers. What do you think?
Yeah, well, I saw you write this, and I purposely didn't write anything about it and talk to you because I definitely have a rebuttal to this. Do you think that you're in the minority or the majority for this?
Well, that's why I wanted to ask. Why I'm wondering. I'm curious. Maybe, I don't know. I look forward to getting up on Monday. I look forward to my weekends as well. I'm not as passionate, I wouldn't say, as you are work-wise. Like, you work all the time. I like having a weekend. But I think it's a pretty good job. Like, I can't imagine doing a job that's...
But do you think your own view is representative of everyone's view? And do you also think that everybody in physiotherapy has their absolute dream job, and everything's right? They get paid the right amount, they work the hours they want, they see all the patients they want, they don't feel frustrated, they feel like they've got access to mentoring, access to education. Do you think that all physios have that?
No. No, I don't. And if you are in a position where you feel like you look at that post and you laugh at it and think this is ridiculous, then I think there might be other jobs or positions out there that might be more suited to you, because like, maybe it's not working in private practice or musculoskeletal physiotherapy. Maybe it is working in aged care, but we're lucky to have a job where there are so many different fields that you can go into. Like, there's women's health, there's nursing homes, there's hospital, there's private practice. So I do think that you're allowed to try different areas if you really hate it as much as some of these people were commenting on it do. And I'd encourage you to take a leap and do it, because I do think that you can enjoy your job more than you think you do.
How easy do you think that is to find? I mean, yes, there's jobs out there.
I feel like everywhere's hiring at the moment.
Yeah, everywhere can be hiring, but is it your dream job?
Don't know, unless you try.
And what happened to your dream jobs over in Perth? Is it easy to just pack up everything and move?
Yeah, go for it.
What about the guy that works as a physio and he's got a family and 2 kids, and he's like, oh yes, my dream job, everything I want is in Indonesia, and I hate the job I'm in now. How easy is it for him to move over there?
Yeah, I get that. I do understand. It just made me personally sad, because I think we're lucky.
Yeah. I think
maybe I'm lucky. Maybe I can't say we. Maybe I can't generalize it to everyone, but maybe I'm just lucky.
Yeah. No, I agree. We definitely both enjoy work, and that's one of the reasons we started the podcast and do the Instagram and enjoy being around, like-minded health professionals. But I definitely see the frustrations of working in healthcare. Definitely, as you said, underpaid for how much empathy you just provide for people that you see. You might see 15 to 20 different personalities every day, and you have to be as empathetic as the first one to the 20th one. You're solving people's problems, and then also, if things don't go right, generally you're the one to blame.
Yeah.
And for most people, we try our hardest to get things right, and we don't always get it right. And we always talk about on this podcast, we don't always get it right. And if there's anyone out there that says that they do get it right all the time as a health professional, I would put everything. That's one thing I'm wearing on black and white. Like, I know that they're lying for sure. The only thing you can really do is try to get a little bit better every time, and that can make the job hard. I do.
Now, having this discussion, and again, this is why another reason why we had the podcast.
Have I changed your mind?
Yeah, well, I'm contemplating this more, and I think
65 episodes.
I think about previous jobs that I've had where I probably wouldn't have said what I just said, and
yeah, I'm the same.
I agree. I think it can be hard dealing with people all the time. I think it can be emotionally difficult at times, particularly dealing with for example, sometimes working solely in NDIS can be a lot to take on emotionally, I think.
Persistent pain
without
the proper mentoring.
I agree.
It's hard. It really is. And, you should pat yourself on the back if you're a clinician listening to this. I mean, for all yes, we're being a little bit negative and saying it's hard, but, the flip side to that is...
It's rewarding.
Yeah.
Very rewarding.
I mean, do you just think, if you look back on the last week, I can definitely guarantee, regardless of whoever or wherever you are as a clinician, you have probably changed someone's life. Like, that's pretty cool to look back and reflect on.
I think from this, now having had this conversation, I would say to everyone...
The opposite.
No.
You're going to go comment and go, I agree, I hate physio.
No, I would say I want everyone to reflect on, like, if you look at that post or if you hear that and you're like, Kelly, you're ridiculous, like, think about it. I would challenge everyone to reflect on why they think the way they think about that post and what that initial feeling is that it gives them. Like, do you look at that and think, that's not right? Or do you look at that and think, who came up with this and what was the criteria? Or do you look at that and think, yeah, I would agree with that. But whatever that initial feeling is, reflect on it and think about why you think that is the case, and think, is there anything that you could do to have a slight change on why you've got that feeling? Or is there anything that you could implement into your workplace or implement into your work-life balance or something to make you, even if it's having a conversation with your employer about your pay, like, so that's probably something that people maybe don't do as much as they could, have that difficult conversation about wanting to get paid more. But yeah, think about it, I think.
Yeah, great. Let's move on to the next topic. And I know a couple of people listen to this, and I assume I know that's where the referral came from. But I had a referral from out of town, found us through the podcast, and yeah, it was awesome. It's always, and it's happening more and more, where someone will come in and say, how, and I'll always ask, how did you find us? How did you hear about Achieve? And they're like, oh, this person recommended us and they listened to your podcast, or this other person from out of town. And I'm like, I know that person because we talked through the podcast page. So that was really cool. It was a plantar heel pain patient who I think we will do really well with, but it was awesome. That was really cool. I was happy with that. Now, on the flip side to that, something that didn't make me happy, probably made me laugh more than anything, and I know people that listen to this podcast, a lot of you are from Newcastle, but there was this ad on my Facebook, and I'm telling you now, it's ads on my Facebook for health professionals. 90% of them have to be from chiropractors. I don't see really any from physio, any from podiatry, any from osteo or anything like that. It is
surely
mostly
you see Dave's face every now and then.
Yeah, but he's not. It's not like. Well, I'm about to explain what the difference is. But in the context of, you can come in and get this $39 initial appointment, and they've just gotten this script sent to them from some marketing agency. You're like, hey, do you have this, have that, this is what we can treat, and it's got a list of every pathology on earth and says, if you have any of this, come in and see me for this $160 assessment, and it's valued at $39. You'd be an idiot not to come in. So always have a read up, always watch the videos. Probably shouldn't, because maybe that's why I keep getting them.
That's why you get them, the algorithm, it knows.
I just think,
it's like, this guy needs a chiro bad.
But this one took the cake. So usually it's just some people getting their neck cracked or their back cracked, but this guy says, and if you see it, he's wearing a black shirt. It said, this is what he says. This is the line. If you've got a spine under gravity, you need a chiropractor. That's it. That is the worst line I've ever heard in my life. Nothing to do with pain, nothing to do with anything, but I could say the same thing.
We're not dissing chiros.
No.
There are probably other health professionals that do it too. The algorithm just knows that you like the chiros, I think.
Yeah.
But that is pretty bad.
Ridiculous. That's like me saying, if you've got feet, you need a podiatrist. It's just horrible.
If you've got muscles, physio's for you.
Yeah. If you breathe, you need to see the doctor. It just makes me hate social media, but also think it's so valuable. And that's why, we do it, because you've just got the ability to reach thousands of people from your lounge room, which is cool because you can promote such a good positive message. But it's also very dangerous because on the flip side, the wrong message, misinformation, which we see all the time, can get shared twice as quick. And we know that misinformation travels, I like that this week, 22 times further than positive good
Interesting.
information.
Because it's got more traction.
Yeah, I didn't read read the study. I just heard someone say
I reckon that's it.
Wrong.
I reckon people on Instagram a lot of the time, or social media, they want to get followers, so they'll just put something so bold out there for that initial bump, and then that's what gets everyone.
But then you don't look like... But if the information you put out is wrong, because most people are trying to sell a course, so the information they put out is wrong, therefore I would think you look like an idiot, but it doesn't seem to be the case. I have a real issue with... I don't comment. I do in my mind. If I see a post that I think, which is horrible...
You try it sometimes.
Yeah, sometimes.
I have to rein you in.
Yeah, I don't know what it is. If I see something...
you like it a bit.
No, it makes me feel like I really get physiological change in my body when I see something. It really makes me feel sick and really upset. I don't know what it is. Like when people think about something, I don't know, it's like when you see a pigeon.
I was just about to say,
you get that
so
feeling.
Anxious today when we saw that pigeon, and then I was just so short-tempered with you.
Yeah, I wish
I was thinking that's the feeling.
Yeah, it's frustrating because I don't want to feel like that, because I'm not the verdict or the God to say this is wrong or this is right. But there is also a line as well that's like, oh, you could probably say this, but sometimes it's so wrong, and you think that's just horrible information that you're giving to people.
Dr. Gregory Johnson.
Yeah. Trying to think of... Yeah, the one that I've been seeing a lot lately is someone will do a post about shin splints. It'll be like, shin splints, explain what it is, damage to the bone, and then the next line will be, what causes shin splints? And it's like, bad ankles, poor posture, weak core, pronation, knee valgus, all this stuff. And then, that is implying that if somebody has that is the cause of their pain, and we know that is not the case. Like, that's a lie. When we've researched that, it doesn't come up true. In the most rigorous of studies, it doesn't come up to be the case, and yet people still do it. One person I did comment, and they said, I was like, great, and I try not to be too mean, but I was like, great, hey, I just saw you said, weak core and bad ankles can cause shin splints, can you link me to the study? I haven't come across anything like this. And the person replied and said, I swear I saw some studies from some physio and pods about it a while ago, and then the new line was, although it has happened to me, I've got bad ankles and that caused my shin splints.
Oh, yeah.
So that's what they were basing it off, yeah.
Based off their experience.
Yeah, anyway.
Yeah.
So you wanted to talk about a lovely patient's email.
Oh, yeah.
I don't know, did they listen to this podcast?
Well, yes, because it says she was listening to our podcast for 45 minutes.
Yeah.
So you've seen this patient.
Yeah.
I've seen this patient.
Yeah.
A long history of bilateral insertional Achilles tendinopathy, and was initially quite limited in how much walking she was able to do. Loved walking, had a goal of being able to run, but just didn't think that was even realistic for her. And I received an email from her that she spent 45 minutes on the treadmill running while listening to our podcast, and she was stoked, and I was stoked, and it was a really, really big win for the week for me, and I think she deserves a huge shout out for that. Very, very impressed with all the hard work that she put in, and just so stoked for her to be able to do a little shuffle, as she called it.
She's lovely.
Yeah.
It makes me think of the archetype, and I guess that goes back to our previous post, talking about the archetype of people that you want to see. And for me, I've somewhat broadly categorized as just someone that's active, that wants to be active. That's the person that I really like to see. I think it's just
people that want to get better, people that are committed to getting better. They don't have to be active. They can want to play with their grandkids, or they could want to be able to stand up and cook for 6 hours. But if they're committed to get better, then I'm so keen to help them. Yeah.
It's different in podiatry, because there's like diabetic foot ulcers, general nail care, dermatology, musculoskeletal sides. I guess it's a little bit different, but I agree. I guess I could change that to people that want to get better, but it's just helping someone, not being the person that does it, because it's all them, but being a part of that journey when someone goes from being able to do 50% of what they love to 100% is incredible. And I saw someone at Stockton Park Run, a patient of mine, and he's the best, probably one of the best patients that I've I don't think I've seen him for a while now, but the most consistent person of all time. He was dealing with an Achilles issue, I think it was a mid portion, and we use PhysiTrack, and you can see the green when they've completed, and every single time it was, and he got better so quick.
It's amazing
how
effective rehab is when people do it. Hey,
and it was incredible. Yeah, he's awesome. He's a runner. Yeah, that was really fun.
Yeah,
good
very
to see
good.
him. And it's great to see them and like, hey, how's the Achilles? And they're like, or how's this? And they're like, yeah, it's going really well. And you're like, that's so awesome. Yeah, it's a good pump up.
I've got another funny little thing to talk about today. Do you think that certain personalities or people can get away with different language? And I mean this quite lightheartedly, but then initially happened quite lightheartedly, and then I was like, I wonder if that actually like can be likened to other language, like in the pain world and things like that. So this week, I was talking to Joe, and he's like, I just heard you talking to your patients, and you say things like lie down on your tummy and squeeze your butt cheeks before you do a bridge. And he's like, can you imagine? So Joe's got quite a dry personality, I would say. It's not I don't know if that dry sense of humor is probably more what I mean there. And if he said something like lie down on your tummy or squeeze your butt cheeks, he'd sound like such a creep. But I think I can get away with it. And then, so I was thinking, like, do you think that can be likened to other language used? For example, like this is just, common phrases that you hear, bone on bone, or what's another one? I've got a bit of a mental blank. But things like that no-sebic language around pain. Mm-hmm. Do you think some people can get away with saying it just based off their aura, and some people can't?
And what do you mean by get away with it?
Do you think that they can say it and it does less, maybe like psychological harm to a patient compared to other people?
Oh, it's hard because it depends how the person interprets it.
Yeah, true.
So
it's probably not to do with the person saying it. It's probably more to do with the person hearing it.
Yeah, it's all to do with them.
It's all to do with them.
It's how they interpret it.
Yeah.
Yeah. I don't say the word tummy.
Yeah, see tummy, if you said tummy.
Yeah, tummy just sounds funny coming maybe from a bloke. I don't know. I can't, there's no problem with it if you do say it.
I say it all the time.
Yeah.
Tummy.
Yeah, it's like how we were talking about I did end up looking at some research. There was definitely nothing in allied health, but there was in physicians. They studied over in the States where was there a difference between how, if a male and a female were to present the same information, how was it interpreted? And if a male presented the information, it was seen or understood to be presented in a more confident way. So the patient had more confidence in what the male said.
Probably because they didn't say lie down on your tummy.
Yeah, I think
maybe I need to get my shit together.
I think it's more just stereotypical from, I mean, how many years ago where it was that women weren't allowed to vote.
Yeah.
And things like that. And how, the elitist... I'm listening to the Barack Obama book again, and he was talking about the global financial crisis, and he got all the big CEOs of all the banks to come in, and it was all like middle-aged men, late 40s, early 50s, just that real archetype of person, with no females in there, no ethnicity or anything, just all white, what do you call them? White something males.
Privileged white males.
Yeah, it's like a Caucasian. I don't know. The people that you would imagine to be in politics. So I think that stems from many years ago, and I do wonder how that translates into research as well. I'm sorry, into us dealing with patients, because I remember you said when you very first started, you felt as though people saw you. Or maybe that was just how you felt, but you felt as people saw you as an inexperienced
Definitely. I would have people asking me all the time how old I am, how many years I'm out of uni,
and
things
I
like that.
never got that ever.
I'd get that multiple times a week when I first started. Less and less now because, I don't know, maybe I look a bit older. I don't know if I do.
When people ask that, I always used to say just several years.
I've always said I graduated in 2018, but maybe I should do that. Be a bit more vague.
Because it could be 7 years, could be 20 years. No, but that's very unlikely. But that can be... I remember that was really confronting for me as a young health professional, where you're trying to show that you're confident, you know what you're doing, and you're like, I need to show this person I know what they're doing, and they ask something like that. It can really... can bring you down. And if you're listening to this and you've been out for 10, 15, 20 years and you don't know what that means, it's because you don't have that anymore, and you haven't had that in probably such a long time that you don't know what we're talking about. But I guarantee it probably did happen. It happens to everyone when they start out as a new graduate. So I wanted to ask you about people that you find they're sore on palpation. So they might have a sore tendon or a sore muscle or a sore heel or a sore knee when you push into it, but they don't have any pain there on functional assessment. So you're not able to reduce their pain, and they don't report any pain throughout the day, but it's just sore for them to touch. How do you approach that? Because I get that quite a fair bit. And people can be worried because they associate, my Achilles is sore. Does that mean I've got Achilles tendonitis? But they don't have any pain when they do any testing or throughout the day. Do you ever have that happen?
I don't know. Probably. But I can't think about it. What do you do?
I just say that, if I was to push into anywhere on the body a little bit harder, it would probably be sore. But the most important thing is, you don't get any pain here. The muscle just might be sore, or the tendon might be sore. That's pretty normal. And just make sure that they understand that it's completely normal to have a little bit of pain here and there if I'm pushing into it. But the most important thing is they don't get pain throughout the day, or they don't get pain when we're testing it functionally.
I reckon I would say something similar. Do they come in? I don't think I would have anyone that's come in purely based off pain on palpation.
No. But when you're doing your testing, so someone's like...
So they would have previously experienced pain during an activity that's brought them in?
No. So someone comes in and they've got let's say they've got a sore heel. Great, I'm doing some assessment, I'm checking other things, and they're like, that was a little bit sore. And I pushed into the base of their fifth net or their peroneal tendon. Gotcha. Just when I'm doing my other testing, purely just palpation testing.
Right.
And they're like, that's actually really sore there. And they kind of think, is it coming from there, or do I have pathology there? But then when you test it and question them further, they don't get any pain there. So just reassuring them that that's pretty normal.
Yeah, I probably just say... that's a tender spot at the best of times.
Yeah.
So really common to get that for through that costovertebral joint area of that sort of thoracic region of your back when you're palpating around. If someone's got neck pain or shoulder pain, and you can be palpating around that area. Yeah. Every single time you palpate someone, I'd say on their costovertebral joint or one of them, they'll be like, that's so sore. And I just say, it's probably sore at the best of times, just a tender area. And then I just leave it at that.
Yeah. Why did your thumb ever get sore from palpating?
Nah, used to get a bit of wear and tear in the old hypermobile thumb, but not anymore.
The thumb's the most common place to get osteoarthritis?
Yeah, it's the first place people get it. If people have a genetic predisposition, then that's usually the first place that it will come about.
Man, I was thinking the other day how many times I've touched. Can you imagine how many? I was thinking to myself, how many plantar fascias you reckon I've palpated?
Do you reckon 1,000? 2,000?
Yeah. Someone said the other day, I was just an idiot. When a patient asked me a question, and I don't know if I would have seen 1,000 heel pains, but I was talking about a nail surgery, and I was like, we're just talking about it, seeing how many patients a week and how many times I would have seen this and how many PNAs. I'm like, I probably would have done a couple of thousand. And I definitely have not done a couple of thousand.
PNAs?
Yeah, and I stopped, and they kind of looked at me like, wow, that's a lot. And I could tell that they were like, whoa, I am confident in this guy. And then I was like, oh, sorry, no, probably a couple of hundred. I felt so bad. I was almost going to go along with it. I was going to be like, and then I was like, I could just keep going. I've done 40,000 of these.
You just do them day in, day out. Don't see anything else. Just do surgeries.
I see 200 patients. I did 200 PNAs a week. But I nearly went along with it, but I couldn't lie. I was true to my morals. But it made me think of how many times and things I would have seen.
Or I reckon I'd see a few back pains.
Yeah, how many times I would have said... I'm just trying to think what's the most common thing. that I would have said. Maybe
load-related low back pain.
Nah, I don't call it that. Or plantar heel pain. I would have said that a lot. Or no, this is probably the most common one that I say. Feel free to steal this. I say, if there is some asymmetry, or they have a little bit more of a flatter foot or a higher arch, I say, great. So, having a look at you stand, and as you mentioned before, you can see one foot probably sits in a little bit more than the other, or rolls out and sits down a little bit more than the other. But when we think about biomechanics and anatomy, we know there's a huge variance. Down one side, we've got really flat feet, and down the other side, we've got really high arches, and everyone in the middle. So it's not so much that our biomechanics and anatomy cause an injury or a pathology. However, when we do develop something like that, sometimes it can contribute as to why it's a little bit more painful, or why it doesn't get better as what we think it should, and say in comparison to someone with a neutral foot type.
Nice.
That's what I'll say.
My one that I reckon I would say the most would be, so one of the reasons that you might be experiencing your painful problem is because I think that your capacity has just dropped down a little bit. So if we say that your knee can only tolerate this much load at the moment, and because it was sore and it's painful, your capacity to tolerate load has sort of declined a little bit because it hurt, and then you didn't want to do things, so then you rested, and then you lost your tolerance to do more things. So if we continue to rest, your capacity to tolerate load is going to continue to decrease. So what we want to do is we actually want to start loading it again. So we need to find what that baseline is of what you can tolerate, and we just want to tinker on the edge of what your knee can tolerate at the moment and see if we can gradually shuffle up your tolerance to be able to tolerate more. I'd say that multiple times a day, I reckon.
Yeah, I reckon I'll put on a bit of a voice, when I speak to
I just
patients.
Put on my patient voice then.
Yeah,
you guys all got a little sneak peek at it.
Yeah, it's kind of, it's almost, I wonder as you become more experienced, are you just able to flip the switch? Like you just be speaking and you turn and talk to people like, oh yeah, hey, so as I was saying, I don't know if it's...
Do you think? I think I've got an initial patient voice, and then I go back to...
Oh, yeah. When,
like,
I definitely
initial
do.
patients is when that voice comes on, and then once I've gotten to know them, I get a bit more normal.
Yeah. I have this, a tick. So, so I walk out and go, Kelly, hey, how you going? Lovely to meet you. And then I'll always...
That sounds so awkward.
Hey Kelly, how you going? Great, come on in, just take a seat there. Awesome. Yeah, how's the day? Yeah, not too bad for a Monday or something like that. or the worst is when because sometimes I start really early. It's like 7 a.m. and they'll come in and I'm like, oh great, how's the morning? Oh, I mean, what's been of it already? And they'll go, oh, well, I've only been here. I go, oh yeah, at least it's Friday anyway. I always use the week or something like that.
I'm really
Wednesday,
bad.
I'll say happy hump day.
I'm bad on Thursdays because I don't start work till 2:30 on Thursdays.
Oh, yeah.
And so I say good morning to everyone. And they're like, well, it's 3 o'clock. And I'm like, oh, shit.
Yeah.
It is 2.
Oh, this is one that I really like as well. Oh, it feels so awkward now I'm saying it out loud, but I always ask around family members, like, hey, so what's family for you? Partner, kids, dogs, cats, that kind of thing. And, if I'm seeing a family go, yeah, I've got a husband and kids, and great, how old are they? And Johnny's 7, and Sarah's just go, oh, great, God, it must be a busy household, hey? And she goes, yeah, you wouldn't believe it, the washing's crazy. And you go, oh, you must do so well, or something like that. But that's one thing that I always...
I'm bad. I do this every time, and every time I say it, I'm like, I need to stop saying this, hey? Like when a patient says like, yeah, I got a 1-year-old and a 3-year-old, I'm like, oh, I bet they keep you busy.
Yeah.
Every time. I'm like,
just they do. But it's nice to have, it's like you agree on that common...
Just trying to build that rapport, I think, is what it's all about.
Yeah, that's true.
Anyways.
Well, that's clicked on
Moving
to an hour. Yeah. Well, let's leave it there. And next week, we don't know, it'll be a very short one, or we might repurpose an old episode because we're going to see Greg Lehman next weekend.
Oh, yeah.
Yeah, that's right. We'll have time. But
that's exciting.
Yeah, enjoy, listeners. Have a lovely week, and we'll speak to you all next Monday morning.